എന്തോ ഇല്ല ഇല്ല പോയില്ല. I think they
okay, it started streaming.
Yeah. Have you started streaming?
Yes, sir. It's streaming now. We'll just send you the link.
I think screen sharing has been disabled. Okay.
Oh, is it? Oh.
Yes, ma'am. We'll just enable it right now. Sir, we've sent the link.
Yeah, thank you. Thank you.
Okay.
Thank you.
Thank you. Sir, we'll begin in 5 minutes. We're just waiting for more people to join.
Okay. So there are two platforms. We can see only 4 people here.
Yes, sir. There are 2 platforms.
Dr. Nittu. Erin, Dr. Nittu has joined.
No, ma'am. Ma'am hasn't joined yet.
Maybe you can just call her and help her if anything.
Yes, ma'am. We're just calling her.
Yeah.
Erin,
Yes, sir.
I think we should get started.
Yes, sir. We were just waiting for Dr. Nitu ma'am to join. We just sent the details again. She is trying to join.
Okay. All right.
2 minutes, sir. Sorry.
Yeah.
Hello.
Good morning.
Good morning. Good
Hey, morning.
morning. Look who's here. Sorry. There's some internet issues with my computer. So.
Okay, we'll get started with the session then.
Yes, Erin, please.
Okay. Good morning. It is my pleasure to welcome everyone today for the pre-conference of Annual Undergraduate International Academic Conference, Spasht 2022. I would like to welcome all our eminent speakers from different walks of life who have come here to share their knowledge and experience to this vast student community. I'd like to introduce the speakers of the panel. First, we have Dr. Kartika KV, Senior Specialist, Hematopathology, Aster DM Healthcare. I welcome you, ma'am. And then we have Dr. Nittu, Clinical Assistant Professor, Department of Physical Medicine and Rehabilitation, Amrita Hospital, Kochi. I welcome you, ma'am. Then Dr. Neeraj Siddharthan, Clinical Professor, Blood and Bone Marrow Transplantation, Amrita Cardio Oncology Clinic, Department of Clinical Hematology and Stem Cell Transplantation, Amrita Hospitals, Kochi. I welcome you, sir. Now I would like to welcome all our participants. We hope that this session is informative and you will get an insight in the advancements of hematology. Now we'll kick off the session. I'll just share the PPT 1 second.
Dr. Erin, it's your PPT you're going to present, or you want me to share my PPT?
Ma'am, we'll be starting with our PPT and then ma'am we'll move on to yours. Okay. Our first topic for the day is diagnosis of hemophilia. So we'll just be giving a quick intro into it. Hemophilia A. Just a minute. Okay, so we'll start with the lab diagnosis. Bleeding time is normal, clotting time is prolonged, but it's not a sensitive test. Platelet count is normal, prothrombin time is normal, activated partial thromboplastin time, which is APTT, is increased. Factor VIII assay, which is essential for the diagnosis and to assess the levels and severity of the disease. Fibrogen assay is normal, FDP is negative. Detection of carriers is by DNA markers, and it's used to detect female carriers and for the prenatal diagnosis of affected fetuses. Hemophilia B, the lab diagnosis. It's similar to hemophilia A, where the bleeding time is normal, but the clotting time is prolonged. Platelet count is normal. The prothrombin time is also normal, and APTT is increased, in which the normal being 30 to 40 seconds, and the factor IX assay is decreased. Now, ma'am, if you could share your PPT.
Can you see the slideshow?
Yes, ma'am.
It's in slideshow mode, right?
Yes, sir.
Your voice is a bit breaking, Karthika.
Okay. Thank you. Okay. Suddenly I got a message that my internet connection is unstable. Just a second.
Now it is better. Now it is better.
Okay, sir. Fine now, sir?
Yeah, yeah.
Okay. So thank you, my dear old students of Amrita, for giving me this opportunity, for remembering me and calling me for this talk. So as you have already talked about in 2 slides, I think I'm going to pull it to 35 slides, okay? So you already know what is hemophilia. I just hope my talks helps you in understanding it better and also getting a clearer idea so that you can build upon it. Okay, always your basics need to be clear so that you can build upon anything on it. So that is my idea of education. Basics need to be strong. So without much ado, let's go to the topic. So today I have been asked to talk about the diagnosis of hemophilia. I'll be talking in general about hemophilia and little bit in elaborate about hemophilia A. Hemophilia B, of course, I can talk about that. But then since we see hemophilia A more commonly, I think I'll talk more about that. Okay, so let's go along with a case history so that it becomes more interesting. So we have a 5-year-old boy who was playing with his friends at home. And afterwards, the mother decides to give a bath to the tired fellow. The boy was excited and narrating how he boxed his friend down. So basically, he had a very eventful play evening. So suddenly, the mother noticed a bluish discoloration on his chest and she felt a deja vu. So I hope your second year MBBS students who have completed your psychiatry. So deja vu is a feeling of familiarity, as if I've seen this before. Okay, so she had that feeling and she therefore took the child to a nearby hospital, and fortunately or unfortunately, you happen to be the casualty medical officer posted here. So what is your thinking? Okay. So this is a scenario you can very well come across in your life. So this was the discoloration which the mother shows on the chest of the child. Okay, so before we go to the history again, now let's come to the basics. What should be running in your mind when you see any kind of bleeding lesion? So you know that it's a hematoma, right? So it's a hematoma which you diagnose from your clinical skills, and then you go back to the basics. You go back to your normal physiology. What are the sequence of events that take place to achieve hemostasis in a normal person whenever an injury happens? Okay, so sorry, I'm missing a slide here. Sorry. Yeah. Yeah. So what happens whenever there is an injury? So the first step, what happens is vasoconstriction. So during vasoconstriction, what the vessel does is it constricts itself so that it can limit the amount of blood loss from the vessel. So whenever there is an injury, the primary concern of the human body is to reduce the amount of bleeding through that defect. So the first step is vasoconstriction, whereby the amount of blood which flows to that area is reduced. And also it results in the concentration of proteins which are required for clotting. Okay. The next step is the formation of the primary hemostatic plug, also known as primary hemostasis, where your platelets come into play. They just come and undergo a series of changes like adhesion, secretion, and aggregation and form a platelet plug. Okay, so you can see this picture. A circular platelet is coming, adhering. There is a shape change. There is secretion of certain vasoactive molecules, and then more platelets come in, and then they form a platelet plug, also known as the primary hemostatic plug. Now, this plug initially helps to arrest the leak in blood, but this is not enough because this is a very weak plug. What we need is a stronger enforcement, which is provided by the secondary hemostatic pathway, wherein your coagulation proteins are involved. And these proteins, they again undergo a series of activation reactions, resulting in the formation of a fibrin plug. So this network-like thing is nothing but the fibrin polymer, which actually creates a cement-like bonding between the platelets so that the platelets are once more reinforced and there is no leakage of blood. Okay, your hemostasis doesn't stop here. Hemostasis also involves not allowing the clot to extend pathologically. Okay, so whenever there is an injury, you want the clot to be formed only at the site of injury. It shouldn't extend further. If it's going to extend further, you will have thrombosis and normal blood flow will cease, right? So you want the blood to be flowing continuously, yet you want the defect to be sealed. So there is another pathway called the fibrinolytic pathway, which actually limits the clot that is formed to the site of injury. So whenever you're talking about normal hemostasis, it doesn't stop with the formation of secondary hemostatic plaque, but it also involves a fibrinolytic pathway. Okay, so any defect in these steps can cause bleeding. So that is the basic lesson. Whenever you see a bleeding lesion, any defect in this normal physiological pathway of hemostasis can cause bleeding, can be the reason. Okay, so going on to our case, the resident took up a beautiful family history, and what he found out was that this child had a history, a family history on his maternal side. The brother of this child's mother had a similar history. So the possible inheritance in this case is an extinct inheritance, wherein you have the females as carriers and the children born to these females, again, only males are affected, whereas females are carriers. Okay, so in this pedigree chart, family pedigree, the sibling of the mother is affected, being a male. So it is likely that this female, that is the child's mother, could be a carrier. Also, this female could be a carrier, we are not sure, but it is likely that a woman with a male sibling with hemophilia and a child with hemophilia is a carrier, is an obligate carrier. Obligate meaning that you don't even have to test her. The history suggests that she is very likely to be a carrier. That is what you mean by an obligate carrier. So this is the valuable piece of information you get from the family pedigree chart. And then now you are concerned about what kind of defect it is. So as we discussed in the hemostatic pathway, it could ultimately be a platelet defect or a coagulation defect. Now the next job you have to sum down on whether it is a platelet defect or coagulation defect. Okay, all this has to be going in your mind when the child is sitting in front of you. So you need to be really thorough with the basics. So what would you think of next? You need to think of how to differentiate between a platelet type bleed and a coagulation type bleed. So there are two things which can help you. One is the type of bleeding, the type of lesion. Next is, of course, laboratory testing. So what in the history can give you a clue about whether it is a platelet or a coagulation type bleed? So the clinical manifestation of the bleed. Okay, if it is a platelet bleed, it is likely to present as mucocutaneous bleeding. Okay, that is, it shows up as petechiae or as your ecchymotic patches. Okay, so it is likely to result in mucocutaneous bleeds as menorrhagia and usually superficial bleeds. Okay, so that is why there is excessive bleeding after minor cuts, and deep bleeds such as hemarthrosis, muscle hematomas are very rare. Okay, and also the rapidity with which the bleeding symptoms develop. Okay, in a platelet type defect, as expected, the bleeding is immediate because the platelets are the first players in normal hemostasis. When there is a defect with platelets, the bleeding is immediate. Okay, whereas in coagulation type factors, the bleeding takes time to develop because they are the later players in your hemostasis. Okay, and the next typical feature of a coagulation factor type bleed or a secondary hemostatic bleed is that they result in deep bleeds. Now, why is it? I can tell you as the discussion progresses. So just remember that defects in the secondary hemostatic pathways usually cause deep tissue bleeding. That is, they cause muscle hematomas, joint bleeds, maybe bleeding after intramuscular injections, such deep bleeds. Okay, you need to remember that they are deep bleeds. Okay, so now going back to the lesion. So this is basically a deep bleed. It's actually a hematoma. It's not a petechia or a skin bleed. Okay, this is where your clinical acumen comes into play. So you examine the lesion again, go back to it, and you try to identify what kind of a bleed is happening there. And you also need to remember that if it had been an immediate bleed, somebody would have noticed. But this was noticed by the mother later when she was giving birth to the child. Okay, so now you conclude that this is some kind of a deep bleed. Okay, so now your mind is going to think whether it's a defect in the secondary hemostasis I'm dealing with. Can they cause deep bleeds? Yes. Can they be hereditary? Of course, yes. Can they be X-linked? Very much. But how do I test it? How do I confirm it? Okay, so now you again go to your physiology, the normal physiology of a secondary hemostatic pathway. We know that the secondary hemostatic pathway is actually carried out by your coagulation factors. These coagulation factors are nothing but proteins which are present in your plasma. They're usually present in the inactive form, but when a challenge comes in, that is whenever there is a requirement for a clot to be formed, they get activated and finally result in the formation of a fibrin polymer. Okay, the cement which we were talking about, the fibrin polymer. So what is the coagulation cascade? We have been reading this cascade every time we learn the hemostatic pathway in your Genong or Guyton in physiology. So it's time to remember that once more. So your coagulation cascade basically has two limbs which converge on a common limb. Okay, so that is called the intrinsic pathway and extrinsic pathway. Recently, the concept of two pathways is being questioned, but at least for understanding the laboratory testing, it is better to read it this way. So there is an intrinsic pathway and an extrinsic pathway, and there are triggers for each kind of pathway. Your intrinsic pathway is usually triggered on contact to a negatively charged surface. Now, in the human body, what is the negatively charged surface? When your blood vessel is injured, okay, when there is a cut in the blood vessel or a cut in the endothelium of the blood vessel, there is exposure of the subendothelial collagen. If you remember the anatomy, there is a subendothelial collagen layer, and this collagen is very much negatively charged. So once the endothelium is injured, the blood is exposed to this negatively charged collagen, and that triggers the intrinsic pathway. Similarly, the extrinsic pathway is triggered by a molecule called the tissue factor or thromboplastin. This again is released from an injured endothelium. So every trigger is placed in such a way that whenever there is a cut or injury to the endothelium, these things get exposed and stimulate the particular pathway. So in your intrinsic pathway, you have factor 12, factor 11, factor 9, factor 8. In the extrinsic pathway, you have only the factor 7. These factors are constitutively activated, like 12 is converted to 12A, and 12A converts 11 to 11A, 11A converts 9 to 9A. So this process constitutes the intrinsic pathway. Similarly, in the extrinsic pathway, 7 is converted to 7A. Ultimately, what they do is either 7A or 9A for that matter, what they do is they convert 5 to 5A, and this 5A converts 10 to 10A. Okay, and this 10A constitutes the common pathway. Starting from 5, it is the common pathway. So the 5 gets converted to 5A, and this 5A converts 10 to 10A. 10A converts thrombin, prothrombin to thrombin, that is 2 to 2A, and this thrombin converts the fibrinogen to fibrin. So this is the normal coagulation pathway or the secondary hemostatic pathway. Now we have lab tests that can assess the separate limbs as well as the common limbs. Okay, so you have the activated partial thromboplastin time, which can show whether your intrinsic pathway is intact, and you have the prothrombin time, which will tell you whether your extrinsic pathway is intact. Now, let's say you have a normal APTT and normal PT. It's likely that your intrinsic pathway and extrinsic pathway, along with the common pathway, is normal. Okay, there are exceptions, but at least for understanding sakes, just remember if your PT and APTT are normal, your secondary hemostatic pathway is likely to be normal. But if your APTT is prolonged and PT is normal, it means that there is some defect in molecules confined to the intrinsic pathway. Okay, it cannot be in the common pathway because your prothrombin time is normal. Okay, so it is a defect confined to the intrinsic pathway. Similarly, if your PT alone is prolonged, it means that the defect is confined to the extrinsic pathway. But however, if your APTT and PT both are prolonged, it means that the defect is in the common pathway. Okay, so this simple tests can help you to actually give an idea where your defect is. You don't have to have a specialized lab to detect such normal, simple tests. Okay, so these tests are available everywhere, and it's about whether you order them or not and how you interpret them in the light of the clinical history. So as I told you, these are actually very easy tests, and if trained well, even you can do it. The prothrombin time consists of nothing but you take the patient's platelet poor plasma along with tissue factor. Why? Because you know that within the human body, the molecule which triggers the extrinsic pathway is the tissue factor. So you need to trigger that exteriorly also, ex vivo also. So you do that with the help of adding synthetic tissue factor along with phospholipids. Any coagulation reaction can take place only on the surface of phospholipids in the body that is provided by the platelet, whereas ex vivo you need to add an external source of phospholipid and then you incubate it and calculate the clotting time. Okay, so this gives you the prothrombin time, and this time tells you whether your extrinsic pathway is intact or not. Okay, next coming to activated partial thromboplastin time, reaction and all is same. You need phospholipids, you need calcium, you need your little bit of tissue factor, not much, little bit. That is why it's known as partial thromboplastin. Okay, you need little bit of thromboplastin, but the extra reagent which is added to the APTT reaction is the activator, because I told you that the intrinsic pathway is stimulated or triggered by a negatively charged molecule. So you need to add a negatively charged molecule like salite, silica, ellagic acid, kaolin, etc., so that you activate the intrinsic pathway in particular. Okay, because a little bit of tissue factor is there. You don't want the extrinsic pathway to get stimulated. You want the intrinsic pathway to get stimulated. So that is why you add the negatively charged molecule, and then you make the reaction specific for the intrinsic pathway. So any defect in the APTT tells you that there is some problem in the intrinsic pathway. So this much you can understand from these two simple tests. Now, this is one question. Being a laboratory physician, which I want to convey all you students, whenever you're collecting blood for any coagulation testing, please collect it in your blue vacutainer or the citrate vacutainer. Okay. So in this child, the prothrombin time of the PT was 14 seconds. The normal is from 12 to 16 seconds. So the PT is normal, whereas the APTT, the normal is 32 to 36 seconds, whereas in this child, it was 75 seconds, which is very much abnormal. So we have come to the conclusion that the APTT is abnormal. Therefore, the defect has to be somewhere in the intrinsic pathway. Not in the common pathway, not in the extrinsic pathway. So which of the factors could be deficient in this patient? We know that the intrinsic pathway is such a long pathway. It has 12, it has 11, it has 8, it has 9. So how do you narrow down which factor could be deficient? Could it be factor 12? Could it be factor 11? I would say no, because factor 12 and factor 11 deficiencies usually do not cause bleeding. They cause thrombosis. Okay, they can be either asymptomatic or they cause thrombosis but not bleeding. Can it be factor 9 or factor 8? Of course it can be, because deficiency of factor 8 and factor 9 can cause bleeding and they can be X-linked. Okay, so you need to remember the entire history of the child throughout the course of the examination. So if the child exhibits a disease with X-linked mode of inheritance, you need to search for a disease which is likely to have X-linked mode of inheritance. In this scenario, both hemophilia A, that is deficiency of factor 8, and hemophilia B, that is deficiency of factor 9, both have an X-linked mode of inheritance. Okay, so having said that, this child could have either hemophilia A or hemophilia B. So what do you do next? Okay, so somebody is telling you this child is unlikely to have a deficiency. He is likely to have an antibody, which is going to reduce the factor 8 levels. Okay, in this case, you can very well justify that because it is an inherited condition, it's likely to be a deficiency rather than an antibody related issue. But sometimes in the clinical scenario, what happens is we usually do not have a family history, such a clear family history, because the mutations can be de novo, can start from that generation onward. So you always don't get a family history. In such cases, whenever you have a prolonged APTT, the next step to go by is mixing study. So what is mixing study? You take the patient's plasma and you take a normal plasma. Okay, you mix both in the ratio of 1:1, and then you measure the APTT of this mix. Okay, so if this APTT is normalized, that is 75 becomes close to normal, like 30 or 40, then it means that it was deficiency. Why? Because you are mixing normal plasma, which provides the deficient coagulation factor and therefore normalizes the APTT. Whereas if this had been an inhibitor or an antibody, what happens is, so in this picture, you can see there are antibodies. What happens is the factors in the normal plasma are also neutralized by this antibody. So there would be no correction of the prolonged APTT. It would still remain prolonged. And that will tell you that you're dealing with an inhibitor and not a deficiency. So in normal clinical practice, if you have a clear-cut family history, you can avoid this step. But when it is not available, you always follow up a prolonged APTT with a mixing study to prove that it is likely to be a deficiency or an inhibitor. Okay, so in this child, the APTT was corrected. It was around 36 seconds after mixing. Now you want to find out which factor is deficient. So you finally came to the conclusion that the intrinsic pathway is defective. It could be factor 8 or factor 9, and it is likely to be a deficiency. So now you want to know whether it is deficiency of factor 8 or factor 9. So there your factor assay comes into play. Usually in clinical practice, we first do a factor 8 assay because it is much more common than your factor 9 deficiency. Okay, hemophilia A is more common than your hemophilia B. So in clinical practice, you do factor 8 assay first, followed by factor 9. Okay, if factor 8 is normal, then you follow it up by factor 9 assay. So what is the principle of a factor assay? Okay, you need a little bit of, your maybe physics or chemistry in this. What you're doing here is you are measuring the APTT of the patient. Why? Because factor levels are inversely proportional to the APTT. Okay, the factor, what is the job of a factor? In giving you a normal APTT. If the patient's factors are normal, the APTT is going to be normal. Okay, but if the APTT is prolonged, it means that the factor 8 or 9 or any other intrinsic pathway factor is reduced. So it is a very proportional relationship. How much the APTT increase, that much your intrinsic pathway factors are going to be reduced. Okay, now you need to make this sensitive to only factor 8. Okay, not factor 9, not factor 11, not factor 12. So how do you make it sensitive to factor 8? You dilute your patient's plasma with a factor 8 deficient plasma. By that process, what are you doing? You are providing all the other factors in excess. So factor 9 is provided, factor 11 is provided, factor 12 is provided. So once you have provided all the other factors, any prolongation in APTT of this mixture is likely to be due to a reduced factor rate. I hope I'm clear. You take the patient's platelet poor plasma, you add factor 8 deficient plasma, which is a plasma which contains all other factors except factor 8. Okay, so factor 8 is not there. Rest of the factors are there. You add this to the patient's plasma. Okay, and now you measure the APTT of this patient's plasma, the mixture of the factor 8 deficient plasma and the patient's plasma. And now let's say the APTT of this mixture is high. Okay, so that means that any increase in this APTT is likely to be a proportional decrease in the factor rate. So this is the property you use for factor assay, and that is why it's known as a functional assay. You're not measuring the antigen levels. You're measuring factor rate as a function of its ability to normalize the APTT. Okay, so don't go into all that. I just want to say that it's a functional assay wherein you're measuring the APTT and thereby assessing the factor levels. So if you measure a normal patient's plasma, it will be 100%. If you measure a patient's plasma, the more you dilute, the more higher the APTT will be, because factor rate is not there in that patient. Okay, so that is how you measure the factor assay. Now, how are you going to measure factor 9? Very simple. You add a factor 9 deficient plasma. So any confusion? I hope I can continue.
Yes, ma'am. Please continue.
So similarly, if you want to measure factor 9, very simple, you take a factor 9 deficient plasma. Okay, so if you take a factor 9 deficient plasma, you are providing all other factors in excess, and any change in the APTT of such a mixture is likely to be due to a change in the levels of factor 9. So this is the principle of your factor assays. So the rate limiting factor in this step is the cost of these factor deficient plasma. So factor 8 deficient plasma, factor 9 deficient plasma, these are costly reagents and difficult to obtain. So that is why every lab doesn't offer you these factor assays. Okay. So because you didn't have that test, you're referring the child to a HTC. HTC is nothing but Hemophilia Treatment Center, where they specialize with hemophilia testing and management. And the child was found to have factor levels of 3%, and you label him hemophilia A. Now, hemophilia A is not enough. You need to label him more. Let's see how you label him. Okay. So a little bit about the history of hemophilia. Now this tablet, stone tablet, is from the holy book of the Jews, okay, Judaism, Jews, known as the Talmud. Okay, this Talmud has an inscription wherein they say that if a lady has a male child and she circumcises him and he dies due to bleeding, she doesn't have to circumcise the second child. And they give an explanation for that. They say that we had a history of 4 sisters. When the first had circumcised her child, he died. When the second circumcised her child, he also died. And then the third circumcised her child, he also died. The fourth was told, you must not circumcise this child. So there were 4 sisters. 4 of them are carriers. And when they had sons, their sons had proper hemophilia A disease. And when these children underwent circumcision, they died. So that is why this is an X-linked disorder, and this was recognized as early as the time of Judaism. That is when the Talmud was written. Another interesting history in hemophilia is in the royal descendants of Queen Victoria. So Queen Victoria, she was a carrier of hemophilia B. So the family had factor 9 deficiency. So hemophilia B was also called as the royal disease because of this reason. So she was a carrier and she passed on the disease to many of her descendants, which actually changed the history of the country. Okay. I'm not sure if you know about Rasputin. Okay, so Rasputin gained entry into the Tsar dynasty, offering to help the child of the empress with hemophilia. So that is why the empress alluded to every request he had made, and that is how he became so powerful. So this disease has a royal beckoning to it, and that is why it is known as the royal disease. So this is hemophilia B. Okay, so why was it named hemophilia? Because of the love for hemorrhages. These childs bled spontaneously, so that is why the disease was named as hemophilia. Okay, a little bit about the genetics. Because it's an X-linked disease, the gene is obviously likely to lie in the X chromosome. It's very close to the G6PD gene, which is also an X-linked disease. G6PD deficiency is another X-linked disease. Okay, so the most common mutations occur between exon 22 and 23. It's a huge gene. Okay, it's a very large gene, but luckily most of the mutations, almost 60-70% of the mutations are likely to occur within this region, that is between exon 22 and exon 23, and the mutation is known as intron inversion. Okay, the region which lies between the two exons is an intron. So it's called intron inversion. It can either be an intron 22 inversion or intron 1 inversion. These are the most common mutations in hemophilia A. Whereas in hemophilia B, the most common mutations are deletions. The entire gene gets deleted because it's a very small gene. Okay, so what is the function of factor VIII? Now we have been reiterating this pathway from the beginning of the talk. So where your 8 comes here and it's here. Okay, 8 gets converted to 8A, helps in converting 9A. It helps in converting 10 to 10A with the help of 9A. Okay, so graphically showing you the reaction, this molecule in the center, the orange color, is the activated factor VIII. So what it does is it brings your factor 9A and factor 10 close together. Okay, because it has binding sites for both factor 9A and factor 10. So it brings them both together so that this factor 10 can get converted. So this step is very, very, very important because this is the amplification step. Factor 10A is the prime molecule in the common pathway. And if factor 8A is there, you can very well tell me, do you need some person to bring these two molecules close together? They will be close together, maybe a little far away. Okay, but no, it makes a big difference. Your factor 8A increases this reaction by more than 1,000-fold, and that is why it is known as an amplified molecule. Okay, so factor 8A is the most important molecule in the amplification step. Okay, your clotting will still happen when factor 8 is not there, but a blood which has to clot in 30 seconds will clot in maybe 10 minutes, 15 minutes, by which the patient will bleed to death. Okay, so that is why factor 8 is a very essential molecule. So clinical features, this is the typical feature of hemophilia A or B. They present as joint bleeds. It's very disabling to the patient, affects the quality of life of the patient. Repeated bleedings can cause arthropathy and fixed joint deformity. Okay, so why? Because your intrinsic pathway is very important in controlling deep bleeds, because the molecule which I was talking about, tissue factor, that is inherently deficient in muscle and joints. Okay, so therefore the extrinsic pathway cannot do anything there. It is only the intrinsic pathway which has to act in these areas, and without 8A your intrinsic pathway is 0. So that is why hemophilia is characterized by muscle hematomas and deep joint bleeds. Okay. So the genetics of the disease, as I told you, there are many different mutations. Most common is your intron 22 mutation. It actually happens due to abnormal pairing. Your exon 22 and 23 fold over itself. So there is an inversion of the intron 22 segments. They become ulta pulta. They are supposed to be like this. They become like this. Okay. So that is why it is called as an intron 22 inversion. And this is the most common mutation in hemophilia. And also it causes the most severe form of disease. Now, what do you mean by severity? Is there something called severity in hemophilia? Yes, it's very important to know the severity, and you classify the disease based on the severity. This is why your factor SA is very important. When the factor level is less than 1%, you call it severe hemophilia. Now, what is the specialty of these patients? They bleed spontaneously. They don't need any trauma. They don't need any trigger. They just bleed. Okay. Now, what is the treatment for these patients? They require factor prophylactically, whether they bleed or not, whether they need it or not, they need factors prophylactically. Whereas there's something called moderate, which is 1 to 5% factors. These patients don't bleed spontaneously. That is the main point. They don't bleed spontaneously. Of course, if there is a trigger, an injury, like a boy, like a 5-year-old champion who had a trigger, a trauma, he had a factor level of 3%. So he belongs to moderate hemophilia, which do not bleed spontaneously. But when there is a trauma, when there is a challenge, hemostatic challenge, they bleed. So what is the management of these patients? They don't they don't need permanent prophylaxis, but when they are going to face a hemostatic challenge, let's say a surgery, a traumatic sports, they're going to play or something like that, you might think about giving factors to these patients. The third category is the mild category, where the factor level is greater than 5 to 40%. And these patients usually do not bleed except when you have a major surgery and unexpected bleeding. So that is, these patients can even go undiagnosed, okay, if they are not going to have any hemostatic challenges in life. So this stratification is very, very important. So our child has to be renamed as moderate hemophilia A, because everything depends on that label. Okay, and this severity of the disease is found to correlate very much with the genetics of the disease. Like, for example, your intron 22 inversions, which are the most common mutations, they cause usually the severe type of disease. Okay. So this genetics can be used in the counseling of the patients, wherein you first identify the diagnosis, and if you don't know the genotype of the patient, you go for the clinical phenotype. Now, let's say I don't know what is the mutation of the patient. I will look into the clinical phenotype. Okay, that is whether it is a severe disease or a mild moderate disease. Okay, if it is, if I know the factor levels and if I am able to classify them as severe or mild moderate, then only in the severe disease I need to do a mutation study. Okay, because as I told you, it's only the most common mutations are seen only in the severe forms. Okay, but if the clinical phenotype is unknown, you will have to do a mutation study in all patients, and based upon the result of this mutation study, if you have got a positive mutation, you stop it there. Okay, if you don't get any positive inversions, I mean, if your gene is negative for inversions, then you go for the more extensive study of gene analysis, wherein you the entire gene. So this flowchart actually helps you to sum down how to do the genetic testing. Okay, so the genetic testing is required because this is an inherited disease and can be passed on from generation to generation. So that is why you need to you need to follow an algorithmic approach. You cannot order all the tests in the beginning itself. You need to go in a step-by-step fashion, because these tests are not available everywhere. Okay, so this flowchart is only for patients who want a genetic diagnosis, so that they can be counseled based on, I mean, they're counseled regarding starting conceiving again, or starting another family, etc. Okay, so that was about the genetics of the disease. Moving to our patient again, child was started on-demand factor therapies because he's a moderate hemophiliac. At the age of 7, he had to undergo circumcision, and the hematologist advised an inhibitor screen. Now, what is this new word, inhibitor screen? Inhibitor is inhibiting. Okay, you don't want anybody to inhibit your factor. You want your factor to function normally, but somebody is inhibiting it. Who is that fellow? He's an antibody. Why? Because factor prophylaxis, what are you doing? You're giving a synthesized protein, artificially synthesized protein, you're infusing into the circulation. Anything like that is bound to create an immune response and antibodies. So sometimes what happens, these antibodies go and inhibit the function of the protein. Okay, here you need the protein to function properly, but these inhibitors prevent the protein from functioning. So that is why you need to look for formation of inhibitors now and then. Okay, so when and all will you look for inhibitors? In patients who are on prophylaxis, that is severe patients who are put on prophylaxis, there are routine intervals where you need to check, because you're giving them factors at regular intervals. Similarly, you need to check for inhibitors at regular intervals before surgery. Why? Because suddenly you don't want the patient to have inhibitors which go unnoticed. When you do a surgery, you give them factors and the factors are not working. You don't want that scenario. So before any type of elective surgery, you do an inhibitor screen. And the third scenario where you will advise an inhibitor screen is when there is an increase in bleeding or increase in factor requirements, meaning your factors are not working as efficiently as they were working. Recently, if I have a bleed, I take 1 unit per kg, it's done. But now I'm having to take 2 units, 3 units per kg, but still my bleed is not subsiding. So in such scenarios, again, you suspect a inhibitor. Now, what is the principle of an inhibitor screen? It's very simple. Luckily, your factor 8 inhibitors are time dependent. That is, they again, see, your factor 8, you give a patient factor 8 that will normalize the APTT. Now, let's say there is an inhibitor in the patient. It is going to prolong the APTT. Okay, but factor 8, the specialty or the typical unique factor which helps its diagnosis is that this inhibitor acts in a time dependent manner. Okay, so I will explain that with this picture. Okay, you have the patient's plasma, which the APTT is prolonged. Now, why is it prolonged? Because there is an inhibitor there. Any factor there is not working. So that is why the patient's APTT is prolonged. And then you add pooled normal plasma. Why do you add that? PNP is pooled normal plasma. You're adding PNP because you want to give factor 8. And you want to see whether this factor 8 is also inhibited. You check the APTT. When the APTT is corrected, and suddenly you think, oh, there is no inhibitor. Whatever factor 8 was there, it went into this patient and then corrected the prolonged APTT. That is what you think. Now, what do? You incubate the mixture at 37 degrees Celsius for 2 hours. This mix, okay? You incubate this mix at 37 degrees Celsius for 2 hours. At the end of 2 hours, you will see that the APTT of the mix gets prolonged. Now, that is why I say factor 8 inhibitors are time dependent. Immediate mix actually shows a correction of the APTT, whereas if you incubate it for 2 hours, you see that the APTT is prolonged. That is because these factor 8 inhibitors take time to inhibit the factor 8. Okay, so they take 2 hours to inhibit the factor 8. So you need to wait for 2 hours, then measure the APTT. And if it is prolonged, it means that the patient has an inhibitor. It's very important to identify the presence or absence of inhibitor because it will change the management of the patient, which you can, I'm sure Neeraj sir will put a word on it. So it is very important test in the management of hemophilia patients, inhibitor screen. Okay, so this is actually the procedure wherein you mix with the normal plasma. Initially, the APTT corrects, but after 2 hours, it gets prolonged. So in such scenarios, you call it inhibitor screen positive. Factor 9 inhibitors, on the other hand, cause immediate prolongations. They don't wait for 2 hours. They cause immediate prolongation of APTT because they immediately inhibit the factor 9. So that is about the inhibitor screen. Now, this is followed by another step called the inhibitor assay. Okay, so there are antibodies in the system, right? Inhibitors are nothing but antibodies. You need to measure the titer of these antibodies, titer, the quantification. Okay, so this is done by the technique called Bethesda assay or Nijmegen-Bethesda assay. So this will be a little complicated for you, but just understand that there is called an inhibitor assay. And this inhibitor assay helps to measure the titer of these antibodies, which will again change the management of these patients. Now, whatever we do is because it is going to make a difference in the management of the patient. So these are the tests which are going to be important if you have decided to start a, let's say, hemophilia treatment center or something. These tests are absolutely essential because every test determines the further management plan of the patient. So in our child, the inhibitor screen was negative. The child had an uneventful surgery under cover of factors. Now the next story, the next visit, the mother comes, she tells you that she wants to have another child. Now, because she knows that it's an inherited disorder, of course, she's going to be apprehensive, and it is your duty to counsel her. Now, what will you counsel? You know that she is an obligate carrier, right? So you know that she has the mutation. Now, what do? There are both invasive and non-invasive tests. Non-invasive tests have become really prevalent, especially in hemophilia, wherein you take the maternal plasma DNA and you do a fetal sex determination. Because this is an X-linked disorder, usually males are affected. So if it's a female fetus, no further analysis is required. And if it is a male fetus, You then identify the mutation from this fetal DNA itself, which is circulating in the mother. But the disadvantage of this technique is that only the common mutations and known mutations can be tested. Okay, otherwise you cannot test for these mutations. So then, if it is a male fetus, you isolate the fetal DNA and you test for the known mutations. If it is affected, you give the option to the family whether they want to continue or not. If it is unaffected, they can continue. Okay. There are other invasive tests available for any disease. Just like in any other disease prenatal diagnosis, you can do your amniocentesis, choriocentesis, chorionic villus biopsy, wherein you get the tissue from the fetus and then you check for the mutation, just like you would do in a normal case. Okay, you sequence the entire gene, etc. Okay, after birth, of course, you can measure the factor levels of the child. Okay, so this is about the prenatal and the perinatal testing which you can do to detect the presence or absence of hemophilia in the child. Okay, so I think this brings me to the end of my talk. And so the take-home message is going to be very simple. Clinical history is the first and key step in the diagnosis of any disease, let alone hemophilia. You cannot forego the clinical history. And particularly in hemophilia, your family history, the type of bleeding, the history which elicits bleeding, everything is important to stratify the disease and manage the disease. A simple APTT can be used for screening. Factor-assays and inhibitor studies are essential for further management of these patients. And prenatal diagnosis is a boon for carrier females because this disease, though there are very developments in leaps and bounds for the management of disease, this disease is still a disease which can strain your resources and quality of life, especially in a country like India. So thank you. I hope I did justice to the topic. Any questions? I'm ready to take them now.
Thank you so much, ma'am, for that really informative session. We are inviting questions in the chat box, so please feel free to ask. Ma'am, there are 3 questions. The first question is, what are the other warning signs in hemophilia?
You mean clinically? I hope it is clinically. So hemophilia is actually a bleeding disorder. I don't think there are any other warning signs. Patient bleeds. The patient can bleed with minor trauma, and sometimes patients bleed spontaneously. Especially in small children, when they start crawling, you can see bluish patches on their knees. When the child is handled by your parents or other people, you can see bluish patches in the place where the child is held. Even small trauma can elicit bleeding in hemophilia. So basically a bleeding disorder. So any kind of bleeding is possible in hemophilia. We had a child with even a ear bleed. Okay. So yes.
The next question is, if inhibitors are present, what is the basic principle in the management of such patients?
I think I'll leave that to Neeraj sir.
Okay, ma'am. There's one more question. What is the life expectancy for a child with hemophilia?
It's a great question. See, with the best of therapy, they have a really good quality of life. Now, best of therapy, the availability of the best of therapy is the question. Okay, so there are factor VIII concentrates. There is a magic molecule called emicizumab which is coming in. The problem is the accessibility and cost issues. Now, if you can conquer that, I think they should have a near to normal life expectancy. I would ask Neeraj sir's help on this.
Yeah, I mean, fantastic presentation, Dr. Karthika, as usual. So, the point, I agree with you that, now in the current scenario with a proper access to treatment, and that is, so they should have a normal life expectancy, but that is not the case. What is happening in our country, because many people are not having access to treatment, and more importantly, many people are not being diagnosed. Okay, so I think these were the point you made out is very valid, that a simple APTT, can from the laboratory side can raise suspicion about hemophilia and bleeding signs in a child. But the question, I think, the warning signs of hemophilia, I think in any child, it can be as simple as, you are putting in a cannula and in a small child, and then there is a hematoma developing there. That could be a warning sign, a very unusual hematoma developing at the IV cannula site, or, an unusual bleeding from, other sites, etc. A keen observation, as clinician for us, when you all go into the clinic, and then you need to watch out for, small, because the hemophilia presentation, as Dr. Karthika pointed out, is in the early childhood. Most of the severe patients present in the early childhood. So you need to identify the warning signals, the warning signs that they present, and then proceed with the appropriate testing. So the combination of both that, developing a clinical acumen and the lab skill, is important in the diagnosis.
Thank you so much, sir. Then we'll start with the next presentation from our side. So our next topic is management of hemophilia. The management strategies include prevention of bleeding, replacement therapy, gene therapy, desmopressin, and other therapies. So in prevention, first we have to control the bleeding episodes, which can be done by local measures, that is to apply direct pressure, elevate or ice compress. And in case of epistasis, we sit up, lean the head forward slightly, and hold the nostrils closed for 5 minutes. Then to prevent joint degeneration, so we immobilize the joint during acute bleeding, progressive exercise, and avoid prolonged mobility, and also avoid contact sports. In replacement therapy, fresh whole blood can be used, or whole plasma, fresh frozen plasma, factor 7 or 9 concentrate. In gene therapy, so as we can see in the picture, so the new gene is incorporated into the viral DNA. The virus is packaged into vesicle where increasing acidity causes release of pentons. The penton toxicity breaks apart the vesicle, and then the virus will deliver the DNA into the nucleus, and genetic information is transferred to mRNA. Desmopressin, the action is stimulates the release of stored factor VIII and von Willebrand factor. Administration is injection or nasal spray. The other therapies include fibrin glue, which contains fibrinogen, thrombin, and factor 13. It's placed in the site of injury to stabilize the clot. ESA, epsilon aminocaproic acid, is an antifibrinolytic which will delay clot lysis. Thank you. So you can begin sharing yours.
Yeah, thank you, Erin. Thank you for that nice introduction of the topic. Can you hear me well?
Yes, sir, it's clear. We can see your screen.
You can see the screen and in the slideshow mode?
Yes, sir.
Okay.
Thank you.
So let me begin by thanking the students at Amrita, the organizers of Spasht, for having a topic on hematology and hemophilia, because I think this needs a lot of awareness in the UG curriculum as well. And thanks to Karthika for nicely showing the path taken by a child who presents with a bleed, and then how you diagnose, and then moving forward from there. So very nice initial talk, so that I think it so I don't need to go into the introductions. I think you can straight away skip some of this which Karthika has already mentioned. So I am going to take you through the management of hemophilia in bits and pieces with history. So if you want to go back and see in the medical literature, the first account apparently has been in United States in New York, and this is the article that the WFH is citing, that it is as early as in 1803, where John Conrad had described in modern medicine after the Talmud description. And then, of course, you see the Rasputin and the European and the English royal family here, where this X-linked inheritance was, well, studied, or the evidence was very clear there. Now, now we are dealing with a bleeding disorder, and most of these victims are males, and very rarely females are also having hemophilia. But it is unlike in many other diseases that we see, like say leukemia. This is a lifelong disease, so that's a very important thing. That this is a patient, if they suffer for lifelong. So. And then what all happens? They bleed into different areas. As you all know, the joint is the most common area where they bleed. And of course, knee joint is the most common area where they bleed into. But in addition to joint, you could have very, very many other bleeds, like you have soft tissues bleeds, like here you can see the gluteal bleed. You can see a bleed in the elbow, which could well transform into a very dangerous compartment syndrome. Another muscle bleed here in the thigh. And then you could have very dangerous life-threatening bleeds like intracranial bleeds also. So the bleeds can happen all over the place, even though the most common is the joint bleed. And this is the natural history without any interventions. So what happens when recurrent bleeds occur? One is, initially you have pain and limitation of movement, but then once you recover, there is blood in the joint, and there is hemosiderin deposition, and then there is inflammation, just like any other inflammatory arthritis. So you would, and then that would lead to a destruction and complete damage of the joint, which subsequently lead to disability and then pain, like you become a cripple. And then, due to very many reasons, the natural history of a hemophiliac is that they die very early in their life. Now, this is where the treatment, which I'm going to talk about later, is going to be very important. Now, both hemophilia A and B, as Dr. Karthika mentioned, are seen in men, and then they have a varying, frequency. 8 is more common in 1 in 5,000 men, and in 9 is in about 1 in 30,000 men. And as this also, I think, this is just a revision class, these slides. So I hope, those of you who joined late, I think severe is less than 1%, and moderate is between 1 to 5%, and anything above 4 and below 40 is at present considered as mild. So, spontaneous bleed is more seen in the severe and some of the moderates as well. But for the mild people, it is almost always traumatic bleeding only. So this is, I'm going to skip this, and a word about carrier. The females with hemophilia, or female relatives of hemophilic patients, like sisters, mothers, etc. They do carry the abnormal factor VIII gene, but they are protected by their normal X chromosome. So the varying levels may be as low as 1%, or maybe even in the normal range, the factor level. So some of these carriers are symptomatic, and then they may also manifest clinically similar to men with hemophilia. But they may also additionally have heavy menstrual bleed and risk of postpartum hemorrhage. So, that brings us to the different clinical presentations of a patient with hemophilia. So, as we mentioned earlier, joint pain is the most common presentation, and joint bleeding. Joint bleeding leads to chronic pain and functional limitations of the joint, which leads to a functional problem for the patient. So functional problem is like for a child, it is that they're not able to do their daily activities. In occupational problems, they're not able to go to the school. For an adult, they're not able to do their normal occupation. then you have life-threatening intracranial bleeding. Bleeding can lead to death. It can also lead to functional limitations. It can lead to cognitive defects. Muscle bleeding, can put pressure on the neurovascular bundle, and then it can cause chronic neuropathic pain. You can have hematuria, and then somebody may present as post-surgical bleeding because you have not been diagnosed earlier, and you put in a knife and then they start bleeding. So most common bleed, as we said, is joint, and then so the joint bleed is the most common presentation by which a patient will come to you. And so, how do you manage a joint bleed? I think as Erin earlier mentioned, there are a few things which you can do even if you don't have the medicine. So those things used to be called as PRICE, the mnemonic. So P is for protect the injured part by keeping it still. So if you have a bleed in the elbow, don't move, keep it still. And then R is for rest, and a rest is, you keep it rested. You don't move it, put a sling. But if it's in the elbow, you put a sling, all right? And then I is for eyes, and there is a particular way of eyes application, which you do on and off. You don't put directly the eyes, you put it in a bag, on a cloth, wrap it up in a cloth and put it 5 minutes and 5 minutes off, on and off, you can keep it. And then C is for compression, and that is like wrap the area, maybe using an elasto crepe or something, or bandage. And then E is elevate, elevate the area usually above the level of your heart. So if it is a leg also, you try to keep it elevated with the help of pillow. So the R, rest, is you can't continue rest forever. You need to, get the joint active, because otherwise you will develop a muscle weakness, etc. So R has been now changed to OL, that is optimal loading. And I think Dr. Nitu may speak about it in her talk. That is, optimal loading is added to, rest is replaced by optimal loading. So you take rest for some time and then you start mobilizing your joint. So then the price becomes police. So now it's called police. So now what else? That alone is not enough. So Erin was mentioning about blood, giving whole blood. Now, so a very, this interesting to walk you all through the history of hemophilia care in the beginning. In the beginning, hemophilia care used to be by whole blood, and then this is a very old article from Florida, and then you can see this university students donating blood to hemophiliac. So the whole blood concept was then further investigated, and people found out what exactly is in this whole blood which helps. They found that it is something in the plasma and not in the red cells that helps the clotting. So then you can see here Judith Graham Poole. She is a doctor, scientist who worked a lot in separating the key component which would work in a hemophilia A, and this is called as cryoprecipitate. Okay, I hope you have heard about cryoprecipitate. It is available in our blood banks. It is rich in factor 8, molybdenum factor, fibrinogen, fibronectin. So this is a very small amount in each bag, about 15 to 20 ml, and then that is very much concentrated in fact, right? So that was the first kind of real concentrated factor, plasma derived, which was produced with the help of technology from the whole blood. Now, once this became available, then it was found that you could treat the bleeds with such kind of factors. And then the person you can see here is a lady from Sweden, and her name is Professor Inka Marie Nelson. And she is a legendary figure in the treatment of hemophilia, because she's the first person who is documented to start thinking about, can we prevent bleed? Okay, till then people started only thinking about, okay, when a bleed comes, you treat the bleed. Okay, so she started thinking, my children who come to me are all getting crippled because of recurrent bleeds. I don't want them to be crippled as they grow into adulthood. No, they want to be very productive adults. So what if, she asked this critical question, what if I give this, factor concentrate or cryoprecipitate, whatever is available, to prevent a bleed? All right. So this is, this was a, a path-breaking or concept then, which later came to be known as the replacement therapy or regular replacement therapy or prophylaxis therapy. So you can see here, she's standing with a patient of hers who was on this prophylaxis. Again, a lot of technology happened over the years, and this you have solvent detergent methods and lyophilization. All these development in physics actually made a tremendous improvement in the care of hemophilia, because this led that from cryoprecipitate, again, you have so many things in cryoprecipitate, and people started thinking about isolating factor VIII from the cryoprecipitate. And with this technology, then you could actually lyophilize or make it in a powder form, the active factor VIII content in the blood, and then commercially make it available for treatment. So that was a very disruptive technology, that the plasma-derived concentrates started becoming available. And the other important thing which happened in the more developed countries, so the first world countries, was that people realized that, okay, this is some medicine which required a venous access, and the patients had to come regularly to the clinic to take the treatment. So like the prophylaxis or the regular replacement, patients were not bleeding. They were, children were doing well. They were not bleeding. Their bleed rates came down dramatically. But then, can they take it at home? That was the question. So another disruptive concept was about the replacement therapy at home, or home therapy. So this came in as early as 1970s, and then people were patients and parents were self-trained to go for infusions, and this has also been found to be quite safe after a proper training. So all that it requires is a proper training of do's and don'ts, and then you could go for a home therapy is what has been proven. Now there was also problems, with every new step that you take, you face new problems. So in the 1980s, as you can see here, the HIV outbreak happened, and the HIV is transmitted by blood. And the boy you can see here is Ryan, and Ryan was denied entry to his school. He was a hemophiliac who developed HIV positive, and HIV positivity, it was a stigma even in a country like US. And then they denied him entry to the school, and a lot more children were actually detected to have HIV at that time, all because these were transmitted through the plasma. So the plasma-derived product had a problem. Okay, this would transmit infections like HIV, HCV, HBsAg, etc. So the safety was an issue there. So then what is the solution? So every new problem, mankind, the scientific community starts thinking about what to do next. So now, if you have heard about the recombinant technology, where, you use, kind of immortal cells like myeloma cells, plasma cells to, make one particular type of protein. And this recombinant technology came into hemophilia after these. So now most of the factor concentrates here that we find are recombinant. Now, again, so now I'm coming back to the problem that we face in the clinic regularly, that, okay, you have a patient presenting with acute bleed, you can give them the factor. So you give them a factor at a particular level. Okay, so you have World Federation of Hemophilia guidelines, and you can, I will request you to refer to the guidelines to find out what level of factors we need for each kind of bleed. And this can be very well calculated. And but then there is also a problem that if you just treat the bleeds alone, you can treat the bleed with the on-demand factor, But then if you treat the bleed alone, then that is not going to be enough. Since my time is limited, I'm not going to go into the details of the doses. But if you want to know about the doses, if you want to know about, you can always contact me, and I'll help you with that. But the World Federation guidelines is a good online, easily accessible, downloadable format, PDF format, where you can go through that in detail. So I want to switch and then move to a topic where you can actually prevent, deformities like this, what you can see in the pictures, from happening, and so that any child with hemophilia born today should be able to lead a normal life without developing any joint deformity. So this concept again is prophylaxis. So there are different ways by which prophylaxis can be given. One is a primary prophylaxis. A primary prophylaxis is before the second joint bleed or before the age of 3. That is when the joints are pristine without any joint damage. And second bleed or later, then if you start prophylaxis, it's called secondary prophylaxis. Why it is called secondary prophylaxis? Because by then, even if you take an MRI or microscopically, you would find a joint damage already happening. So primary is technically before a joint damage. Secondary is after joint damage, but before onset of the joint disease clinically. Tertiary is you have a patient who's already got a bad joint and it's manifest, and then you're starting. And then prophylaxis can also be given for surgeries and also for some sports, etc., where they have short term, or for physiotherapy, etc. The on-demand, as I said earlier, is just for the bleeding alone. Then you give supplementation of the factors at the time of the bleeding alone. Now, so as always in medicine, we go by evidence, right? So we need to look at the evidence of each of these and then take that into account before planning a treatment. So the evidence is usually created in studies, prospective studies, and then randomized into 2, right? Then one you give the proposed treatment, and one you are not giving the existing standard of care, right? So the existing standard of care was not a prophylaxis, it was just on-demand treatment, and the proposed treatment was prophylaxis. And then they followed up these patients for a very long period of time, years together, and looked at the joint MRIs. And you know what they found? That they found that the patients who were on prophylaxis had significantly lower joint problems compared to those who were not on prophylaxis. So there are different types of prophylaxis, and this is from the World Federation of Hemophilia guidelines, which I mentioned earlier. So you can have a high dose, intermediate dose, and a low dose prophylaxis. Why the 3 doses? The 3 doses are conventionally taken from 3 different areas of the world. High dose prophylaxis was practiced in Sweden, where we mentioned Dr. Inga-Marie Nelson and her colleagues and her followers there. An intermediate dose prophylaxis, which was a bit lower doses, but with almost similar outcomes, but a little more bleeds, was in Netherlands. And the low dose prophylaxis has been a stepping stone for people in developing countries or low and middle income economics, like in India. So I think I don't want you to mug up all these values, etc. Just stay with me on the concept. So there are also you can actually tailor the prophylaxis based on, suppose somebody is a very physically active child. I mean, he wants to go for sports, etc. Then you need to keep his trough levels of factors high. So generally, if you look at when you give factors, you have a peak level coming like that, and then with the passage of time, the factor level drops like that. So, and when it reaches a trough level, a very low level, then you should give the next factor. So the trough is actually what is protecting you. And if the trough goes below 1%, then there's a higher chance of the child developing a bleed again. So, if you are a very physically active child, you don't allow the trough to go down that, and you keep the trough above that. So there are different troughs you can have for different activities. Like for a sedentary person like me, if I was a hemophilia, I would require a trough of only 1%. So And so for a toddler, you need probably a trough level of 3-4%. And for a very old patient also, you'll need a trough level because they are, frequently injured. So those people, you need to keep a higher trough level. So that is pharmacokinetic or clinically guided pharmacokinetic, and you tailor for each, rather than keeping a fixed dose, you kind of tailor your prophylaxis regimen. All right. So the clinical, of course, is, you take a clinical call on this. You don't do a pharmacokinetics. This pharmacokinetics, you can have softwares to do the pharmacokinetics, but you can also tailor it based on your clinical need. The softwares are generally used in resource-rich situations where you want to optimize your, but in resource-limited situations like us, we generally go with the more of a clinical decision. So I wanted to bring attention to one study, actually an audit that we did once we started prophylaxis in our place in 2015, and then published this in 2016. And then you can see that we compared the same patient 6 months while they were on demand, and then compared them after they were on prophylaxis. And what did we compare? We compared their bleed rates. You see the bleed rates had come down. We compared their hospitalization rates, and that has come down. And you compare their school absenteeism. You see, most of the children, the school absenteeism crashed, actually. Most of them started going to, that's the most, rewarding thing of this, that, it all became better. And then, of course, the HJHS and FISH are the functional scores of the joints and other joint scores. So there was also some improvement in those scores while on therapy. So we subsequently had been following up these kind of patients, and then made sure that this effect is, consistently there. So then subsequently also, you can see that the bleed rate, hospitalization, and the school absenteeism had been statistically significant. Now, so if you see the mean, and I'm just go back to the bleed rate. Now the median bleed rate initially was around 11, and then it dropped to around 0.9 while on prophylaxis. That is about for the 6 months. So in a year, it was about less than 3. So the 3 bleed rate is generally important, because this study showed that anybody who develops more than 3, Muswi study showed that anybody who develops more than 3 joint bleeds in a year actually goes on to develop a severe joint damage. So if at all, 0 is always best. Go for a 0 bleed, but if at all there's a bleed, try to keep it below 3. That's the message that the Muswi study says, and that's been now what we should. We are also planning to achieve for our patients that. So subsequently, the prophylaxis cohort in our patients, starting from 10 patients, now it has picked up to more than 100, and it has spread to the entire region, in the sense for the state as well as in the country. There are many, many more patients right now on prophylaxis. And then on different doses, right? So some doses low and some is high. But anyway, after prophylaxis therapy, you can see that before, if it was 23 bleed rate, and after it drops to 3. So it's a good beginning, it's but then we could do better, right? So how can we do better? Now we have more products. So, right, we have now got extended half-life products. So extended half-life is like you here within 48 hours, as I mentioned earlier, you reach a trough level of maybe less than 1%. But here, for an extended half-life product, you are going up to 300 hours. So that is fantastic. So is the extended half-life a different thing? So there are 2 primary methods by which you create extended half-life products. One is fusion engineering. This is basically you can fuse it with albumin or FC, portion of immunoglobulin. The other option is to go for a pegylation. So it is either an albumin fusion or an FC or immunoglobulin fusion, or it is a pegylation. So if you fuse it, and then you actually increases the half-life. Now, for factor 8 and factor 9, it works a bit different, very interesting. Factor 9, when you do this extent, this fusion or pegylation, it dramatically increases the half-life to 3 to 5-fold. And you actually, if you need a factor infusion every alternate day for a standard half-life, but for extended half-life, you may need it only once in 2 weeks. Factor 8, it is not that much yet, as yet, but now it's about 1.5 to 1.8 fold, but it still helps you to increase the interval of the prophylactic frequency. So this figure, actually, I wanted to draw your attention to the factor 8 extended half-life here and the factor 9 extended half-life here. You can clearly see that, both the 8 and 9 clearly helps us to reduce the number of injections that you give to a patient on prophylaxis, and clearly much better in factor 9. So yeah, so Erin was also mentioning about some other newer therapies, and Kartika was mentioning about emicizumab. So I'm going to try and in the next 5-10 minutes, maybe I'll try to cover all this, including the DDAVP, antifibrinolytics, etc. So inhibitor development is a complication which Kartika mentioned. About 30-35% of hemophilia A and about 10-15% of hemophilia mild A and about less than 5% of hemophilia B have inhibitor development, and it leads to ineffective therapy. So as mentioned earlier, it is checked by a Bethesda, and then you have 2 types of inhibitors: a low responding inhibitor, which is less than 5 Bethesda unit, and most of the inhibitors, that 75% of them, are high responding, or more than 5. There's some difference in the way by which we manage the low responding and the high responding inhibitors. In a very low titer inhibitor, generally we tend to continue the factor replacement only. And even in the high responding inhibitors, there is a concept called inhibitor eradication using immune tolerance induction. That is essentially nothing but giving the same factor again and again and again. So it is like you have developed an inhibitor to the factor, but you keep giving the factor, maybe at a higher dose and consistently for at least about 9 months. And then you can see that in maybe in 1/2 to 2/3 of the patients, your inhibitor will be eradicated. It is kind of the concept called tolerization. You keep giving the same stimulus to the body, keep giving it again and again and again, and wear the body's immune system out. And then you can get over the inhibitor. So that is the concept, and that's the only effective treatment to eradicate inhibitor. All right. So, and then there are debates about who needs ITA and who some people inhibitor are not clinically significant. Not going into the details of all that, but then in those who are likely to benefit, ITA or immune tolerance induction should be started earlier than later to prevent a non-responsiveness later. But in the patient with the inhibitor, if he develops a bleed, then the factor is not going to be effective. Factor is going to be likely to be effective in bringing down the titer, but then you could give bypassing agents if the patient bleeds. And there are 2 bypassing agents which have been approved. One is activated prothrombin complex concentrate, which again contains 2, 7, 9, and 10 in the activated form. And then you can have a recombinant factor 7A. So these are the 2 agents which will bypass and try to promote clot in the presence of an inhibitor when the factor is not effective. So, but for preventing a bleed, the bypassing agents are not really very effective. So this is in this context that I wanted to just briefly mention about emicizumab prophylaxis. Emicizumab is this is a paper in NEJM in 2017. This is a molecule which was discovered in Japan, and now it is called the wonder drug in hemophilia. And how does it act? So again, a test of if you have listened to Kartika's talk well, then you should know that hemostasis is the most important thing in hemophilia, is that you should have factor 10A protection. So, and if you don't have factor 8, then you should have factor 8 is the one which brings together the factor 9 to factor 10 and results in activation of factor 10A, which then results in thrombin generation. So if you don't have factor 8, or if you have antibodies to factor 8, and then this is a molecule where you have a bispecific antibody which binds to 9A as well as in 10 and brings together 10 and then activates 10. So, and then that results in thrombin generation and a clot. I can see that, this is going to be very effective in patients with hemophilia A with and without inhibitors. And the beauty of this drug, I mean, you can see the bleeds, annualized bleed rates are really, really low. And we can, most patients even achieve 0 bleed rates with this drug. And the beauty is that, you can see that unlike the factor, the pharmacokinetics is quite different. You can give once a week, once in 2 weeks, or once in 4 weeks subcutaneously. And you need an initial loading. Maybe it may take 1 to 4 weeks for the initial loading. Usually it takes 4 weeks. And after the 4 weeks of loading, where you give weekly, you can even give once in a month and subcutaneously, and there is no trough. It just keeps sailing, very smooth sailing. So at a minimum, it doesn't convert you to a normal individual. You still may be subnormal hemostasis, but that keeps you going, and you could do all kind of normal activities while on this drug. So that's something which is very, very, very important. And then you can see here that the number of 0 bleeds are really, really good, and 0 to 3 bleeds, almost 90% of them are 0 to 3 bleeds. So this brings a whole new concept of balancing the hemostasis. As we all know, now there are in hemostatic pathway, you have so many things which say all 8, 9, 11, 10, 7, 2, fibrinogen, all it is tending towards clotting. And then you have anticoagulants like antithrombin, proteinase, protein C, tissue factor pathway inhibitor, which are anticoagulants. So you have coagulants and anticoagulants, and then in balance, the body keeps it in a balance. What happens in hemophilia? When you have a factor VIII deficiency, the balance goes in terms of, it goes towards the bleeding, it tilts towards the bleeding. And if you have something like an antithrombin deficiency, it tilts towards the thrombosis. So now what this brings, if in a hemophilia, if you actually knock off the antithrombin, that is what people are trying to do now. Now they've brought an siRNA or a small interfering RNA to knock off antithrombin. That drug is called fitusiran, and then rebalance the hemostasis. And again, another target right now being tried is tissue factor pathway inhibitor, and that is called concizumab. And so these are, we are trying to rebalance the hemostasis, and there have been a lot of papers coming up, especially more so with fitusiran, and in the last American Society, this results were published. These drugs are not yet in market, but of course, you have to be cautious of not the balance going not too wayward. Thrombosis could be one risk. So the trials should tell us about the safety aspect, but I think barring the initial concerns, now the result seems to be good. And the same with concizumab also. Both of the drugs are not in market now. Finally, about gene therapy, and which is the curative therapy. Basically, you have different vectors like viral vectors like adeno-associated viral vectors, which then is integrated into the patient, and then the integrated cells produce sufficient amount of factor 8 or 9. So here you can see factor 8. There are so many trials going on now. This is a recent publication in NEJM again, where there was sufficiently good response over a longer period follow-up for factor 8 gene therapy. So at present, I should mention that there is a gene therapy trial going on in India also, that is in CMC Vellore. So this is a curative concept. Okay, there's one concept that you could live with hemophilia without bleed, and that, of course, and then there's also those of them want to get cured, and now the gene therapy becomes a very exciting option. Okay, now to finish off, now a word or two about the other supportive drugs. So desmopressin, as you know, it increases the factor VIII level and von Willebrand factor by releasing it from the endothelial lens. And it's not useful in severe hemophilia, but it's useful in mild and moderate hemophiliacs. And generally, you will see a twofold level increase in factor level. So it can be either given as a nasal spray, and then the dose is depending on your weight, whether you are less than 50 or more than 50. But there are a few toxicities to it, so which we have to be aware of, and including hyponatremia and fluid retention. And so you need to restrict water while using desmopressin. And yeah, so I mean, after 2-3 days, the effect wears off. It becomes ineffective. So limit the use to about 2 to 3 days whenever you're using the desmopressin. So among the antifibrinolytics, basically that's a supportive drug. It's very useful in many patients with bleed because it helps to form the clot and stabilize the clot. And so except for where you have the genitourinary tract where a clot can obstruct, and so in other bleeds where it is contraindicated, but in other bleeds it is usually very useful, and it's usually we don't combine it with FEBA because of the risk of thrombosis. So I think I'm now coming to the end of my presentation. So I will try to answer a question which one of the participants raised after Kartika's presentation. And if you can look at this graph, you can see that this is showing a life expectancy in United States. In 1900, it was 13 years. In 1960, it improved to 20 years. In 1990s, it improved to about 60 years, and now today it is almost like a normal life expectancy of like compared to any other normal person. So I think the message that I want to convey is that hemophilia can be effectively diagnosed and treated. And in India, it shouldn't be any different, but we should all put in more effort, I think, into getting more people diagnosed with hemophilia, because I think in India, we have about 20,000 people diagnosed with hemophilia, but actually there should be much more. About 1 lakh should be diagnosed, but we are under-diagnosing, and we need to improve the diagnosis of hemophilia. And also, many patients are not on prophylaxis, and so we need to optimize the care for patients by putting everybody on prophylaxis and home therapy. So this is a challenge which I will invite you to take up once you finish your course and if you are interested in practicing hematology. Thank you very much for this opportunity once again, and I'm happy to take any questions.
Thank you so much, sir. There is a question in the chat box. What are the recommendations for the management of COVID-19 in patients with bleeding disorders?
Well, so I think in general, COVID time, there are a few concerns which were raised, which is, I think this is not relevant to the topic. So if you want me to answer the question, the questions raised during COVID times was about vaccinations in patients with hemophiliacs, number one. So I think the vaccinations can be done, and it was an intramuscular injection. So patients who were on prophylaxis, we have advised them to continue their prophylaxis and go ahead with the vaccinations, and then apply pressure immediately after the. And it's a small, go for a smaller needle, and then apply pressure with reasonable 5 to 10 minutes of pressure, so that the bleeding doesn't happen. So almost everybody got vaccinated. All this hemophilia patient community has got vaccinated, and not had encountered a problem after vaccination. With regards to the disease, COVID-19 is more, what we have seen is, as we all know, it's most like a thrombotic disease. It has more thrombotic tendencies. So its hemostasis is tilted to the other side of theoretically, hemophilia patients should be benefit. I mean, we should be protected from some of the thrombotic effects, but I don't know. I don't have a data to answer that. But I think in the hemophilia community, I've not seen too many patients with severe COVID. I have not seen myself, but I don't know.
Okay, so there's one more question. There are hormonal replacement options for treating hemophilia A, but why aren't there drugs to bypass the coagulation cascade altogether?
So just can you repeat the question again? Sorry.
So there are hormonal replacement options for treating hemophilia A, but why aren't there drugs to bypass the coagulation cascade altogether?
No, there are not I wouldn't call hormonal replacement. There's not. Hormones are usually what I mean, it's like corticosteroids, thyroxine, etc. are called hormones. So there are not hormonal replacements in hemophilia to treat hemophilia. The bypassing agents are definitely there. In fact, I mean, see, the entire pathway is very complex. So in the entire pathway, if you bypass, I mean, if you have to bypass the entire pathway, then what you have to get? You have to get a thrombin generation, and then you have to get a fibrin clot. So this is very important. A thrombin generation and a fibrin clot is important. Yes, we are able to, for a hemophiliac, yes, we are able to bypass that using drugs like factor 7. That's a good bypassing agent. For hemophilia A as well as hemophilia B, it bypasses the entire pathway and then results in thrombin generation and a fibrin clot. So yeah, that's definitely there. Although some of the rarer factor deficiency that doesn't work well. But bypassing agents are there. I don't know if this answers the question, but if not, then I can clarify.
So there's one more question. Will long-term emicizumab cause hypercoagulability of blood, especially in CLD patients or patients with metabolic disorders?
Hyper or hypercoagulability?
Hyper, sir.
Yeah. So the emicizumab, when it went into the initial trial, Heaven trial, there were safety concerns because most of the patients who developed, there are a few patients who developed thrombosis and thrombotic microangiopathy. Now, those were very strictly the patients with emicizumab who had also received factor VIII inhibiting bypassing agents at a low dose higher than 100 units per kg per day. So the combination of emicizumab plus factor VIII inhibiting bypassing agent is tricky. And if you have to use it, but never go up above that dose of 100 units per kg per day. And if at all somebody bleeds on emicizumab, it is better to use factor 7 as a bypassing agent if you are an inhibitor, or if you are having a non-inhibitor, you can still use factor VIII. But after the initial safety concerns, there has been these regulations and these guidelines have come that, okay, if you're using it FEBA, use FEBA at a lower dose. So now this paper, which I showed, if you remember the date of the NEJM paper, it is 2017. Now another 5 years have passed. It's very interesting to note that there has been no more safety concerns with emicizumab in the last 5 years. So I think people have now mastered how to use emicizumab, and in the last 5 years, there are many people who have taken them. So many of the hemophiliacs have a CLD. They've been on this medicine. So as such, the emicizumab is not going to correct the hemostatic pathway to 100% also. So it's staying somewhere below there. That's all I can say right now. That we have also not seen. We have started using emicizumab for the last 3-4 years, and we've been quite careful. I must admit that we've been quite careful whenever we are using a new drug. But So far, the safety signals have been very encouraging. But a long-term, other than the 5-6 years, then we don't have the experience now of any drug. We will have to keep monitoring for any potential long-term effect. So far, it looks promising.
Okay, sir. Thank you so much, sir. We'll be moving on to the next topic. So we'll be starting our presentation.
So the next topic is yttrium synovectomy. Yttrium synovectomy is one of the latest methods of treatment introduced for treatment of recurrent hemoarthrosis in patients with hemophilia. It involves an intra-articular injection of yttrium 90 citrate to treat synovitis. Yttrium synovectomy have shown reduction of the number and size of the synovial villi, small filiform fringes developed from the synovial membrane, and with decreased hyperemia in the early phase. Chronic synovitis in hemophilia, rheumatoid arthritis, and villonodular synovitis earlier only had surgical options until the option of injection of radioactive material was used to fibrose the synovial proliferation to control disease progression. Dr. Nitu Devasi has introduced this concept for the first time in Kerala last year. Ma'am, I hope you'll continue from here onwards.
I cannot. Can I share my screen now? Yeah.
Yes, ma'am.
Can you see it?
No, ma'am.
Now?
Not yet, ma'am.
I tried stopping my share, but still this thing is coming there. No? So should I let me just.
Now? Now? Is it seen now?
No, ma'am.
Okay.
Ma'am, are you able to share it now?
I'm just fine.
Okay. There's an option for share screen at the bottom.
Yeah, I pressed the share screen and they said open preference. I clicked that, and then, but I can see it, but you can't see it. So open system preference.
Ma'am, if you keep your presentation open on your laptop, you should be able to share that.
Yeah, it's open. Hmm.
Ma'am, do you want us to screen share it? Ma'am, if you send us the PPT, maybe we can screen share it for you.
Okay, right.
Yeah.
Can you tell me your email?
Ma'am, you can just send it to Amrita on WhatsApp, if that's possible. Or ma'am, if you want an email ID, I'll just text.
You get it?
Ma'am, have you sent it on the mail?
Mm.
Yes, ma'am. We just connected. Ma'am, we didn't get the mail. Ma'am, could you just?
Yeah, I'll just try it.
Yeah.
Can you just check now? I think now it's.
It just said now. We'll just check.
You got. Okay, there's something wrong with the email.
Yes, we haven't gotten it till now. Just...
No?
Yes, ma'am. We're still the mail.
No. No.
No, ma'am. Still haven't received the mail.
Okay.
Ma'am, could you send it on WhatsApp by any chance?
Dr. Nitu, what is it saying? What's the issue?
There is some when they're saying I can't share it. I
Yeah.
press the share, open system preference, and then after that, when it's loading security and privacy, and I can't click the Zoom. I'm not sure why I can't click the Zoom.
Ma'am, we've received the mail. Ma'am, we'll connect it as soon as we can.
Okay, thank you. You got it, no?
Yes, ma'am, we've gotten it. We're just connecting it to the computer.
So I'll start.
Yes, ma'am. Yes, ma'am.
So, good morning, and thank you so much for waiting patiently for me. I am so honored to be here. And I remember being an MBBS student. I had needle phobias, and one day somebody told me that I would aspirate joints from small children and take out the blood and all. I would be horrified, I think. So it's just how much I'd seen the impact radium had done to the joints and the quality of life that the children had who actually got the treatment is why I had started doing it. Like both the most fantastic speakers had spoken earlier, the celebrities who had the hemophilia was someone like Queen Victoria and But now, if you just Google who's a celebrity with hemophilia, you would find sportsmen, athletes who would, I think, I don't know if you know of Alex Dosset. He is actually a cyclist who he cycles at the rate of 52 kilometers per hour. So even when we have discussions worldwide, nobody in the developing countries have bleeds, or if they have, it's just once in a while. Whereas we had kept camps here and screened. Majority of the patients that I saw was severe, and in them also most of them have joint bleeds, and it's always not one joint, it's multiple joints, and they've always had deformities secondary to it. And even like adolescents, 15 to 23, those age groups, arthropathy started already. So um, we can, I think the role of physiatrists are doctors who deal with physical medicine and rehab. What we work as a team is to improve the quality of life, or we look at function. So there's an international classification of function, and what they say is like any patient with a chronic disease, it can be a child with hemophilia, and if he has to, like how sir said, he has to go to school in the morning, he has to walk to the bus, climb those big steps, from the where the bus stops, he has to go to class. So the daily activity is affected, and even if when the child has to any activity, it's recess period, he just wants to go out and play with his friends, that is restricted. Most children are extremely upset because they are set apart from the other children. And you'll have to move the slides for me. Okay, yeah, this is the international classification of function. So activity limitation is a huge problem. Participation in their activity, it's a problem. Environment, you know how bad the road is from Lulu till our hospital. There's potholes everywhere. So it's a problem. It's an actual problem. If you go to the Western world, nobody will allow them to make roads like this. And sometimes you see personal factors. I've seen patients who don't have so extremely talks for anything. So that is also a huge problem that we see in patients. Can you go to the next slide, please? Next slide. Yeah. Okay. The one before, please. The one this. Okay. So secondary to this, we have a problem. The joint as such, there will be deviation. How can we do it? So exercise and shade between if it's a bleed or if it's synovitis. If it's a bleed, it would be there will be pain, swelling. It would be tight. The patient won't be able to load that joint. And if it was whereas in case of if it's synovitis, it will look swollen. It will have a doughy kind of consistency. It will not be a hot, tight mass. It will be when you feel the texture, it's more doughy. It won't be so warm, and the patient used to be able to load that in. And chronic synovitis, it happens when you keep on, they have recurrent bleeds and inflammation to the joint. And exercise is key. Like, people think that yttrium is a wonder drug. It is a wonder drug, but we're giving yttrium to reduce the amount of bleeds. But if you don't exercise, the use drug is going off. So I've seen so many patients who think that, okay, I don't have to exercise, I just have to come and get it done. But no, that's not the case. And the more they exercise, the more the joint is protected by the quadriceps. If you the knee joint, the quadriceps muscle would go around it and it will actually stabilize the joint. Okay, and next slide, please. Next slide. Yeah, so this was one boy who came with his mother practically carried him there, and only with exercise his bleeds had reduced. Whereas so that should go to the child, like, they should know that is the effect of it. Then sometimes when you have recurrent bleeds, you can't even exercise. That's like they have 4 to 5 bleeds, so by the time the bleed settles and they start exercise, they bleed again. So then the treatment is secondary prophylaxis. You put them on secondary prophylaxis, and then automatically the bleed rates will come down. If it still doesn't work, then we go in for synovectomy. So definitely it might reduce the frequency of bleeds, but it's not like for some patients, yeah, the bleed has completely settled. Then if the proximal muscles, if the quadriceps, they keep buckling, or then the joint will become very unstable. So you'd be careful. And the best part about this compared to a surgery is for surgery, it's a one-time procedure, whereas for this, you can repeat the procedure after 6 months. Maximum at a point, you can inject 2 joints. Next slide. So the advantages is it's relatively less expensive. The risk of infection is lower. There is no loss of range of motion. That is a big thing, because sometimes that's a problem in surgeries. And you don't need general anesthesia unless it's a very small child. So I just do it. I don't even give a local injection. I just apply Prilocaine, the local that you use even in dermat. So just that is applied, and then we go in for the injection. I've asked patients personally, was there any pain while you get the injection? There's usually no pain at all, and it's not at all not very invasive. You don't need 100% factor cover. That's a big thing, because for all surgeries you need 100% cover. For this, you don't need that. Next slide, please. Yeah, so this is how Neeraj sir said. The joint would keep bleeding. There will be synovial inflammation. That recurrent hemarthrosis causes the synovial hypertrophy and impingement. So that is what atrium can reduce, because eventually all these patients, they into hemarthropathy, and we're just finding ways how we can delay the process. So next. So exercises. There is a lot of exercises, but the compliance is usually very bad. And what isometric is when you can just contract, relax. So those exercises is what we start immediately. Some patients, they don't exercise for a long time, and then suddenly they decide to exercise and they have bleeds. They'll just start cycling and all, and they'll have bleeds. So that should be avoided. Then slowly, very, very slowly, we can go into free exercises, then to resistance exercises, half kg weight training, and then quarter kg every 2 weeks, and last weight bearing exercises. If you go this slowly, you don't need factor cover. But otherwise, if you are slowly, you want to give a program and then send them fast, maybe it's better off to give them the exercise with factor cover. Next, please. So next, so what can we do if you develop deformities? That is very common. So one is exercise. Next, please. So with exercise also, we can work with strengthening the joint. But if that doesn't happen, skin traction to straighten out the joint. Serial casting is something that we do, which is next, please. So what you do is you cannot put pressure to, so that if a joint is flexed, we cast the limb from above knee to below, around near the toes, and we make the patient prone. Okay, so only with the power of gravity it will stretch out. You will not put any additional pressure, and then we'll wait for it to solidify. After 1 week, at that, that popliteal angle, we can make a small cut and then we can let it stretch out. And we make something like a triangular wedge of plaster of Paris, and then you insert it there. Slowly, 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 we stretch out the whole joint. It usually takes around 6 to 8 weeks to get at least 10 to 15 degree of correction. And during this period, we should keep the child nearby to observe. Next. We also have something known as a knee brace. If you see at the knee joint, you can see there is a dial lock there, and it will actually stretch the joint in that position. There's also something known as serial casting. You can cast under anesthesia. This you definitely need factor support, and you can stretch out, but it's a little complicated and it might bleed, and the surrounding, even the soft tissues will be involved. Next, please. Now, you should always think, how did the patient bleed? I have patients who come with weeks, but it's usually they were traveling in bus, or there was an exam just recently, and so you can see that brace on the right side. So that is something that I ask them to use. All these patients, according to the latest Persons with Disability, hemophilia is added, so you can ask for extra time. All the actions that would increase the strain on the joint, like squatting, okay, all those would we would advise them to avoid. Next, please. So the exercise is something that's very key, and I'm not sure if I've said the videos for. Is there a video attached to this? No. I think it's not.
No, ma'am, sorry, I was not able to play the video.
There was a video.
I'm not sure. No, I don't think so.
Okay, I'll see if I can send you a video. So I'll just by the time it okay.
Ma'am, we'll take questions then in that time.
Yeah, sure. So I usually what we do is when the patient comes to the OPD, we assess the joint. There's a hemophilia health score, and we assess 6 joints, and that is both the elbow, the knees, and the and we see how well they score. So it must be like if there's any swelling, if there is any other problems like joint, how bad it's affected. Then we look at the target joint bleed rates, like how Neeraj sir had said. And if there are more than 3 bleeds in 6 months, that's when we plan to, okay, we'll inject this child or not. Sometimes you do, like sir mentioned, there's a fish score. That's a functional score. Like, can you take bath on your own? Can you climb steps? Can you dress on your own, standing on one leg? Things like that. We also do the scale called a Peterson score, that is for joint health. So this we take an X-ray and see how bad the hemarthropathy is. Because if it's very severe, then it's hard for arthropathy. Patients will have pain due to the arthritis and might not be because of the synovitis. And we do an ultrasound. The ultrasound, we try to look for Baker's cysts. Suppose you have a Baker's cyst, there's a chance that it might cause a bleed into the it can, like the the yttrium that we inject, it can go into that Baker's cyst area, and that can cause fibrosis in that area, so that should be avoided. Then something that about yttrium. Yttrium is actually a beta emitter. So I think you must have seen all these patients who take radioactive substances for their thyroid. So that is a gamma emitter, and you have to be isolated. Whereas yttrium is a beta emitter. Its wavelength is only 2 centimeters, and if you inject, it's only 2 centimeters that the radiation will be affected. So usually the whole lining is the only place where it will be it will go. And to get this drug, where we get it is from the same place where CMC also gets it. It is in France, and from there we usually get the drug. And first it comes to there's a department known as the nuclear medicine. It comes to the hot lab there, and then we split the drug. And once we get it bedside, we aspirate the joint and then inject. Once we inject this drug, we have, for the first 48 hours, we have to immobilize the joint. And sometimes there are huge collections, around 50 ml of blood was there in one child's leg. So if you don't aspirate maximum, there's a possibility that it can get diluted. Now, I've done this for patients with hemophilic chronic synovitis, but there are also conditions in rheumatoid arthritis, the joint can get very proliferative and the whole joint lining can get damaged. Also for chronic villonodular synovitis, that is, I've not seen many of them, but the disease process, it keeps on worsening, and it keeps on bleeding into the joints. So for those patients, last time we had injected one patient with that problem also. The outcome is almost all of them had a reduction in bleed, but only around 3 to 4 had completely no more bleeds after the injection. So that is something that I always tell the patients, because sometimes they expect that if it bleeds after that, sometimes the drug takes around 3 to 6 months to fully fibrose the lining. And immediately after we inject also, we should mobilize the joint a little bit so that the yttrium flows through the full synovium. And after that, we immobilize it for it to act. Its half-life is only around 64 hours. So it's only during that first 48 hours, we will separate them and immobilize them. And then after that, they can do all the daily activities. Complications that it can have is this drug which we injected, it can flow back. So that can cause burns on the skin also. So that's why after we inject this, followed by this, we inject steroids. And just to clean the tract of the three-way cannula, we give a little bit of saline, and we give compression and then bandage it. And sometimes the lymphatics of the knee, it lies around the medial aspect of the leg. So yes, sir.
No, I have a small video of yours. If you want, I can that in my email. So
okay, yeah.
You want me to share that and play?
Yeah. Please, sir. Yeah. So this drug, if it spreads through the lymphatics, that is why there's something known as a bone scan, and we do the bone scan after that also. It's so unfortunate the videos are not playing.
You want
Thank
me
you,
to
sir. Yeah, please. Yeah, sure.
Oh. No. There's some problem. Sorry.
Yeah, I think there's something, but yeah.
Sorry.
Actually, those video. Can you show that earlier slide?
Huh?
So I could show them that also. Yeah. Okay. So yeah, this is that first boy who came to me. That's how big synovium looked like. It was very swollen. This is how synovitis looks like. The whole prepatellar area is all boggy. Even it doesn't look, when it's a bleed, it'll have a tight, warm texture to it. But this is my first 5 boys, and out of them, all of them are going to school and to colleges. But see, if you observe what is in my hand, there's this 5cc syringe, but around that there's a guard. I don't know if you can see it. It's like a spherical guard with 2 millimeter. This because it's made out. It's a beta emitter. So just to protect myself, and that guard is used. I do this only ultrasound guided to make sure that it is in the joint, because this is basically, it will fibrose the synovium, the subsynovial plexus. It is actually fibrose it. Okay. So you can see the improvement. So first guy had around 48 bleeds and 0. Second guy had 25. It only reduced, but like you can see that the bleed rate is significantly reduced. Um, our department, they had made a really nice video on this.
Just share this. Okay, can you see this now?
Yeah. Oh, okay. Oh, okay. Thank you so much, sir. So,
Ma'am, we have questions for you.
sure.
Ma'am, there's one question. Is there a target age group for using yttrium synovectin?
When I screen initially, I look if there's any chances of hemarthropathy. So even in the 15, ideally it is the pediatric age group. Now, you know, pediatric is up to 18. So that age group, it is very effective because arthritis is only starting. So the youngest I've injected is 7-year-old and the oldest is 23. The youngest, the joint was so easily accessible, but you have a very child who's really scared. So that is something that, but his joint was not fully damaged. So the earlier is always better. Whereas the 23-year-old, it is very difficult to go into the joint line because of arthritis. The joint space will reduce. There are osteophytes. It was the drug. After we injected, we would do a bone scan. So we saw that the drug was only on the medial aspect, and I opened it and I mobilized the limb, and then again that did a crepe bandage and immobilized, because that is how thin the joint space had become. So but you see patients who exercise very well, the joint space is very healthy. So that is why I have that screening protocol. Many patients who are 35 also have surprised me with a very good joint health. So it is abroad, they've done studies on more than 500 patients and they have injected everyone. But slowly, as my experience grows, I know that the younger the better. Before the target joint gets completely, hemarthropathy completely destroys the joint, we should go and fibrose it so that the bleeds, because hemosiderin will damage the joint slowly. So before that happens, we should go in and inject. Now, like most of the below 18 years, all children are getting prophylaxis, but the adults are not getting it so much. So we put them also on prophylaxis, reduce the bleed, and only then inject.
Okay, ma'am, there's another question. In adults with inflammatory arthritis and persistent knee synovitis, does yttrium synovectomy improve pain and function?
If the pain is due to arthritis, the pain will not change. But if it is because of the synovitis and the bleed alone, it will change.
Thank you so much, ma'am. Now we'll be having the vote of thanks.
Yeah.
Good afternoon, everyone. I'm honored and lucky to have the opportunity to give the vote of thanks today. Firstly, I would like to thank all the speakers for their valuable time. We have learned a great deal and very much grateful for the knowledge. Thank you. Next, I would like to thank all the organizing teams, volunteers, teachers, and staff members. And finally, I want to thank all the participants for your presence here. Thank you.
Thank you.
Thank you.
Thank you so much.